welcome. And so indeed, I will be discussing about COVID-19 convalescent plasma, and I would like to convince you that it's still currently meeting an unmet need, and that it's something that we should clearly continue to think of. Early on, so this is 2020, we had a new disease we needed to treat. Various options. One that's some antiviral drugs, some of them went through, that's remdesivir. Some others, which was also possibly increased immune response, has not. It was chloroquine as an example. Anti-inflammatory antibodies, the anti-IL-6, that has happened to be a major drug. And then there was passive immunotherapy, which was clearly felt that it would be an option that we should consider. I know. I'm sorry, but
yeah, it is quite annoying. Let's see if this might work. This is a delay.
this work.
Okay.
Yeah. Oh, there we go. Okay. So if we zoom on the immunotherapy aspect, so very quickly, so there is convalescent plasma, we'll be talking about it. There is polyclonal antibodies as a possibility, obviously monoclonal antibodies, which has been a very important aspect of treatment. Convalescent plasma, if we continue to zoom on this, it has been used to treat various infectious diseases, and notably severe acute respiratory syndromes of viral etiology, be it Spanish flu, H1N1, SARS-CoV-1, MERS-CoV. There has been some evidence of efficacy, but limited overall, and no formal proof of this. Other type of disease, hemorrhagic fevers, we and others have tested convalescent plasma as a treatment for Ebola disease and reported that, at least in the conditions we use it, it was found not to be effective. However, there are some differences with another hemorrhagic fever I don't know much about other than reading about it, which is Argentinian hemorrhagic fever. And I'm going to spend just a minute or two, because I think there's a lot of very important things we can learn about this disease caused by the Junin adenovirus, and it's transmitted by a mouse, and obviously in Argentina. Because in fact, it's currently the recognized, let's say, treatment. Convalescent plasma is still today the recognized treatment of this disease. And it had, to the difference of the viral infections, there has been some good studies done. And this is a Lancet study from some time ago. It's a randomized trial, randomizing immune plasma to normal plasma. You can see there's quite a striking difference in mortality, 6.5 versus 1.1%. So that was establishing some form of efficacy for sure. But also, and importantly, it also showed that we needed to come in with high titer convalescent plasma with a lot of antibodies. And as you can see here, the mortality was 0.55% if you had a very high titer versus 8% if you had a low titer. So clearly inviting us to think about antibody content of what's in the plasma. And lastly, also quite important to show that we needed to treat early. And this needed to be done within 8 days of illness if we were hoping to have an effect. So all that important information had led to the development of this disease and establishing a program for the treatment of AHF. Interestingly enough, and I'll get back to that, there is some adverse events which have been described, and notably encephalitic symptoms and fever a couple of weeks after disease onset in about 10% of patients treated with convalescent plasma. More rarely in patients not treated with antibody, but still existing, and overall effect. Pathophysiology currently not well understood, at least of what I could read about it, just to keep in mind. But basically, what this was telling us is for efficacy, we needed high titer plasma and early administration. And that's something clearly that we've been able to demonstrate now, I think, in the field of COVID-19 convalescent plasma. I'm not going to spend a long time here, but just to say that early on, we did notice that there was a very brisk immune response with antibodies produced in every patient, except for the immunosuppressed patients I'll be talking about later. But that brings us to the idea that we can have plasma with antibodies. These antibodies have very classic immune functions, be it virus neutralization, be it antibody-dependent viral lysis, be it presenting antigens to the cellular part of the immune response, or what we call ADCC, antibody-dependent cytotoxicity. This brings us to the fact that we can collect this plasma from these convalescent recipients now, patients now donors. It's quite classic. It's something which is done by all blood establishments. You have in the UK started again this plasma collection not a long time ago, but there is clearly a know-how with blood establishments And this is what we call apheresis plasma, and this could be outside of COVID-19, plasma for direct therapeutic purpose, or plasma for fractionation. This, why would we want to collect this plasma? Again, for antibodies, and it could be polyclonal antibodies, it could be anti-tetanus antibodies, anti-hepatitis B, anti-rabies. And on a more experimental side, I had mentioned what we had done with regard to Ebola disease, but also more recently, interestingly, plasma with containing anti-HLA antibodies directed again against a transplanted organ which had been associated in the context of immune deficiency with a refractory graft versus host disease. And by infusing plasma with antibodies against the donor, we were able to show in an isolated case, but published, that we were indeed able to induce a remission of an acute graft, of a refractory chronic graft versus disease. So convalescent plasma was starting to be collected by the Établissement Français du Sang, which is a French transfusion public service, in end of April 2020. Briefly, very standard ways of collecting it. 14 days of delay since the end of symptoms resolution, at least. Standard apheresis procedure, 650 mLs. A donor qualification, which is completely standard for the usual testing we do on any kind of blood donation, in addition to what the measurement of antibody content and notably neutralizing titers. I'm not going to go into the detail of the different ways we do this, but there is significant heterogeneity across different ways and different jurisdictions with regard to this. I'll get back to that later. The plasma undergoes standard testing for pathogens. It is pathogen reduced, and that's something that we do in France on part of our plasma, and is cryopreserved for use as a convalescent plasma. And if it doesn't have an appropriate level of antibodies, it then goes as a standard plasma for general use. And I think that's important because that allowed us not to lose the plasma we were collecting as convalescent plasma. It could be used if the titer is not appropriate within the more general transfusion purposes of plasma transfusion. So we initiated a randomized clinical trial assessing what we now call CCP, COVID-19 convalescent plasma, in COVID-19 patients hospitalized early for severe pneumonia. I'll get back to that. At the same time, we initiated a CCP monitored access program, which was authorized by the health authorities, and allowed for the use of CCP in similar ways than in the trial, but in a more general sense in hospitalized patients. And here I just show you the number of patients included every week since May 2020 up to now. And as you can see, we've basically never stopped. And we have between 0 to 80 patients a week who receive convalescent plasma, and currently we're stuck around 20 to 30 patients a week, and we don't see a reduction. And I think that's going to be important in saying so. All of these patients are now all exclusively immunosuppressed patients, but I'll get back to that. So if we want to summarize a lot of data up until the recovery trial, which I'm sure you all know about, a fantastic trial which was led by you and colleagues, and locally these escort and colleagues, was that all this put together, there was no evidence or little evidence of efficacy of a convalescent plasma. I'm not going to spend time here, but in particular, the recovery trial had an odd ratio of 1, really right in the middle, not favoring one or the options which had been tested. Up until recently, that goes through a systematic review, just highlighting that perhaps things have changed somewhat, but there is still an incredible amount of uncertainty about if there is indeed any kind of efficacy with regard to the use of convalescent plasma. So why do we want to continue nevertheless and treat still patients today? Several issues I think important to consider. Antibody dosing in the plasma is probably important. And I'm not going to go into the details of these studies. This was in the New England Journal of Medicine. It was a monitored access program in the US, 3,000 patients who had received 1 unit. And they were shown there that in specific groups of patients, the patients who had received high titer, and this was completely random, the patient, when the product was issued, they did not know what was in that product. It was associated with a more favorable prognostic in these patients. That was first piece of information. Another study done in Argentina, which I'll get back to later, this is plasma early on, before patients are hospitalized. And as that study, which was a positive study, by the way, showed that for the patients who had received a high titer, the reduction in the risk of hospitalization in these vulnerable patients was at 73.3%, versus only 31% if it was low titer. So there again suggesting that titers antibody content was important when issuing these blood components. And this is a German study called CAPSID trial. Overall, it was a negative study, but when one looked into the patients who had received high titer versus low titer plasma, once again, it's completely random. There is no ability to choose what plasma those patients were receiving. And just you can look at the probability of overall survival. And there's a clear difference between the blue curve, which is the patients who receives a high titer plasma, versus the red curve, which is a low titer. The red curve very close to the control group, which is the yellow, the green curve. So I think rather strong data about the fact that we should look into the dosage. Other aspect is timing. And there are also a number of studies, probably some of you know, this is against the Argentinian study I referred to earlier, which, as I mentioned, was a positive study with regard to the fact that early on, that is less than 3 days after the initiation of symptoms, that is really is short, the plasma is efficient in such a setting. This was an American study, which was not a positive result up front. These were patients who were at the emergency department in the US and were referred to for COVID. And they were randomized, expecting that so for those who were asked to stay, to go back home. The issue with this trial was that a large number of patients, some patients were immediately hospitalized. And so when this data was reanalyzed while taking out those patients who had been immediately hospitalized, there we start seeing differences in between both arms. So it's not a positive result, but it's a trend towards a positive result. A more positive result is this, again, another study in the US, where show this time it's not in vulnerable patients. It's again early plasma infusion. We are at less than 7 days, within 8 days after symptoms. And you can see that the output here, the endpoint is hospitalization, the frequency of hospitalization, and there is a clear difference. 7% in the control group with controlled plasma versus 2% in the convalescent plasma. And lastly, just to cite a combined report of 2 studies in Europe, which was a negative result. However, when we looked at patients which were treated early, less than 5 days of symptoms at time of randomization, there was something which trended towards a good result with an OR of 0.6, but just going the same direction. So there is a lot of data, I think, suggesting that early infusion, as in the Argentinian hemorrhagic fever, is telling us that this is a way to go. At the same time that all that data was generated, in France, we had this monitored access program, and we started using plasma in immunocompromised patients. In late 2020, we reported on the first series of patients with B-cell lymphopenia, typically a patient who received anti-B monoclonal antibody treatment, who were having prolonged forms of COVID-19, and showed in this first series quite remarkable results. 16 out of the 17 patients had improvement of their clinical symptoms and were put out of the hospital. There was 1 death only out of the 17 patients, and no adverse events were reported. And so this got us very interested in using convalescent plasma in such a setting, and brought us to systematically use it only as that indication further on in 2021 and 2022. To be able to try to get a better proof outside of a randomized study, as we did here, how do you call this? A propensity score analysis, comparing as much as well as we could patients who had been treated with COVID with CCP versus patients who had not been treated, and in this study did this propensity score analysis and showed that in a significant amount of patients, this is 81 patients with B-cell lymphoid disease versus a group of 120 patients, which were compared as much as they could be compared. We showed there was a reduction in mortality with a reduction of 63%. Across different controls, different groups here, but I think the most interesting is the population which was treated with the anti-CD20 antibody, which showed a evidence, not yet proof, of efficacy of CCP. Interestingly, in the United States, there was a similar study which was done in a slightly larger group of patients, which showed exactly the same type of results. we had here an OR of about 0.6. And here we have it as well here. The OR was at 0.6 also as a multivariate analysis is the overall population. Once again, these are hematological cancers, very similar to what we showed earlier on. So very similar results. Here and elsewhere, but was led by colleagues in the UK, the REMAP-CAP study, which was a large international study, I'm sure you're aware of, which was in hospitalized and rather sick patients, a big proportion of these in intensive care units. This was a negative result, but it did show that within patients with immunodeficiency, as you can see here, there is a signal, what you call a trend towards favoring convalescent plasma in that population, and that resulted in REMAP-CAP now being reopened for compromised patients and currently recruiting internationally. So this brings us to our clinical trial, which is a small trial, which I would like to report to you, which is called the CORI-Plasma study, which is a study which aimed to evaluate the ability of CCP to improve early outcome in patients with a moderate to severe COVID-19 pneumonia. It's a multicentric, open label, Bayesian randomized adaptive phase 2-3 trial nested within a cohort, which is called the core-immuno cohort, and to test a superiority hypothesis. These are adult patients with COVID-19 since less than 10 days since symptoms initiation, and with up to 3 liters of oxygen. So this is focusing on patients who have been hospitalized since not a lot of days and do not need intensive care type of treatment. The treatment was a randomized assignment in between 4 units of convalescent plasma plus usual care versus usual care. And the outcomes were 2 of them: proportion of patients who had worsened at day 4 after randomization. So really a very early outcome assessment. And a second outcome at day 14, which is a proportion of patients with non-invasive mechanical ventilation, additional immunomodulation, or deaths at day 14. A number of secondary endpoints, which I think are quite classic, including obviously survival, and a predefined subgroup analysis, and notably for the immunosuppressive status. 120 patients were randomly assigned, so this is really a small science trial compared to notably recovery for sure. 60 patients were analyzed in each arm. This is a recruitment pattern for a long time, quite flat at a time when there was summer of 2020. There was not a lot of circulation of the virus and of patients. The plasma was produced as described earlier with regard to the way the EFS was preparing it, with no very significant differences. Just to highlight that later on we will have increased the threshold for the convalescent plasma, but not for that trial. So the outcome, when we looked at day 4 primary outcome, the percentage of patients who had worsened was of 22% in the convalescent plasma arm and 14% in the usual care. This is not a statistically significant difference, but it's certainly not in favor of convalescent plasma. If anything, convalescent plasma is worsening the status of these patients at day 4 after randomization, which is about 48 hours after the last plasma infusion. So that's the first primary outcome. The second primary outcome was that day 4 was a bit better, but not really satisfactory in a sense that at day 14, so deaths or worsening or additional need of additional treatment, all that put together brought us to 30% in both arms. So it was getting slightly better, but it was a null result at day 14. So the overall result of that trial is a negative result with a trend or something to think about what could be happening early on. When you look at day 4, day 7, and day 14 with regard to the WHO scores, which is from 1 to 10, you can see that at day 4, as noticed in the outcome, patients treated by convalescent plasma had a slightly higher median score of disease, and it progressively improved with an odd ratio of 1.42 down to 1 at day 14. None of this being statistically significant, but once again saying that things seem to be improving over time. Now, what does this translate in terms of survival? This is a survival curve, so there's overall not a lot of mortality in this trial. And if there is a difference this time, the difference is in favor of the convalescent plasma, with an odd ratio at day 14 of 0.4 for mortality and 0.51 at day 28. Because there's a small number of patients that does not reach statistical significance, all we can say is that there's probably a trend towards a better survival in patients receiving convalescent plasma. In the subgroup analysis, looking now at the patients with underlying immunosuppression, similar trends, but the curves seem to separate a bit more. And we have now an odd ratio of 0.39. The confidence intervals are not as wide, but it does not stay over 1, so it's still not significant. But nevertheless, with once again, the idea is that if there was a direction which can be given here, it is increased survival in the patients receiving convalescent plasma, and this is within the patients who are immunosuppressed. It's a limited number of patients, as you can see, 21 patients in the convalescent plasma group and 26 in the standard treatment group. But to highlight that, and to say that when you look at the other patients, so those at least not reported as within immunosuppression, you can see that there is no difference. So basically, if there is a difference, it's within the immunosuppressed patients, and it is with convalescent plasma. So in conclusion, this trial tells us that CCP did not improve early outcome in patients with moderate forms of COVID-19 pneumonia, that there was a trend towards CCP-associated early transient respiratory worsening, as well as an increased day 14 and day 28 overall survival. And that's, again, these are trends for both of these aspects. And that when one looks at the subgroup of immunosuppressed patients, there may be a stronger signal, but still it's only a trend of reduced mortality in immunosuppressed patients treated by CCP. So at this point, I would like to focus on this observation, which once again is not statistically significant, but did get us intrigued and wondering what this could be. Is indeed convalescent plasma able to induce some form of pulmonary worsening? And as you may know, and has been discussed in a number of other settings, is the fact that it could be what we call antibody-dependent enhancement or enhanced respiratory disease, was a question mark. And this was a review in 2020, which develops the idea, which has been described with dengue virus as an example, but also with RSV or measles, where you have two distinct mechanisms by which antibodies could be mediating enhanced disease or enhanced infection and possibly enhanced, let's say, viral replication. One mechanism is for macrophage tropic viruses, such as dengue virus, where antibodies can increase viral infection of monocytes or macrophages via the receptor for the FC receptor by the FC receptor of the IgG mediated endocytosis, and it can result in more disease, and it can result in the production of infectious particles. A second mechanism is for other viruses which are not able to directly infect cells such as macrophages, and that's what you can see for, as an example, with the measles, is that we have a formation of immune complexes with viral antigens, and notably into airway tissues, resulting into pro-inflammatory cytokines, activation and complement, and basically lung inflammation, which is very much what we do see, by the way, in COVID-19 and causing an acute respiratory distress syndrome. Early evidence suggested that if anything of this existed for COVID-19, it was more the second mechanism than the first mechanism. Also, at the same time, some more in vitro and animal and mechanistic studies with regard to that was able to demonstrate that one could isolate antibodies directed against various domains of the spike antigen of SARS-CoV-2, being RBD-UNTD, and that some of these antibodies demonstrated a capacity to mediate Fc gamma are dependent or independent infection enhancement. So this is not disease enhancement, but infection enhancement. And that both type of these antibodies, which were capable of enhancing infection, were, to the contrary, able to protect in vivo against SARS-CoV-2. And experiences in monkeys showed that despite this overall favorable effect of these antibodies, some of the monkeys tested here, 3 out of 46, had higher lung inflammation scores when treated by antibodies before improving their disease. And so I find this interesting with regard to what we were observing in our study. And we continue looking into this and now look into what has been reported with regard to adverse events with convalescent plasma. This is an American study in transfusion, where it basically did report a significant proportion of what's called here disease of adverse events in these patients, and up to 9% of adverse events, which is a significant proportion in general when compared to what's usually reported with in transfusion medicine. In another study, I'm not going to detail, in a much larger group of patients, you don't see how many patients there, but I think it's over 10,000 patients reporting adverse events in the US, enables us to give us some figures. And so I'm not going to go into the detail, but just to say that something that does strike us is when you look at what's reported usually in standard hemovigilance programs. It could be, I think, SHOT in the UK or our hemovigilance programs in France. You have per product a frequency of allergy, as an example, or of what you call TACO, which is overload, transfusion-related overload. And so you get frequencies out of 100,000 blood components. And so, you know, this is what's reported in France for both of these frequencies. And now, just as a small exercise, if you take what's reported as the hemovigilance data, let's take allergy. So 114 per 100,000. So there's obviously underreporting, that is for sure. But that's what the figure we have. And you look at what's been reported with regard to the CCP program in the United States. So it's 95,000 patients here. It's 95,000 transfusions there, in the US versus 260,000 plasma transfusions back in France. You see that's a TACO allergy, is 116. So it's basically the same frequency, 114 versus 116. No difference for the allergies. However, there's a significant difference for what's called globally the TACO and the TRALI, which is the inflammatory response you can see after transfusion, where you have a very significant difference in frequency. So does that just mean that because these were patients which were hospitalized for pneumonia, they were very much looked at their lung function and that there was much less underreporting? Is this really something which is does exist in terms of increased frequency? I think it's things we still don't know, but I think it's interesting to report. Was this seen in other studies? And so this is a recovery study that, you know, basically the answer is no. And it was looked at carefully here with regard to various respiratory endpoints, and there is no difference in between both groups in a very large study. Another study, which is the Sullivan study I referred to earlier, here also not reported, no differences. Another study where we did see something, this is a Spanish study with a randomization of 350 patients. There were a couple of cases of patients with severe worsening of dyspnea, with suspected TRALI, which was not confirmed, which was transient. All patients recovered. So there are sometimes some signals elsewhere of similar findings. So what could all this be? I just put back this slide, my earlier slide, just to remind you of this odd, adverse event seen in this patients with a completely different disease, which probably has a very different, let's say, type of organ dysfunction. But just to say that, is this something similar happening here? I think we really don't know. But what we do know about COVID-19 is that it's been looked at very carefully, and it has been clearly demonstrated now that this is notably in this paper in Nature in 2022, is that antibody-mediated SARS-CoV-2 uptake by monocytes, macrophages, does trigger inflammatory cell death that aborts production of infectious virus, but causes systemic inflammation, which could look very much as to what we have possibly observed. Interestingly, vaccine recipient plasma does not promote such antibody-dependent monocyte infection. So it could very much depend also what type of convalescent plasma you are using, and could be possibly linked to convalescent plasma from donors which have not been vaccinated, which was the case early on in the trials for COVID-19. So this as a hypothesis, I'm not going to go into this, but a second paper came out about the same time, basically said similar things, that human macrophages upon SARS-CoV-2 infection activate inflammasomes, release IL-1, IL-18, and that if you block the inflammasome activation, it will lead to the release of infectious viruses. So this mechanism of inflammation is really reducing viral replication at the price of an inflammation. So possibly this could be things which are happening there. And if we get back to our figure here, the possibility is that there is indeed an uptake through a let's say, macrophagic there is an uptake by the macrophages of the virus, but instead of producing active virals, it in fact inhibits it, and it induces the inflammation, which is seen as thought up to recently with regard to what could be the result of the antibodies produced after SARS-CoV-2 infection. So basically, I did develop this because I think it's an interesting observation. We don't know too much what exactly to think about this and how to push forward, but there is, so once again, the possibilities of a transient lung worsening early after COVID-19 convalescent plasma transfusion. And importantly, two things. One, it doesn't seem to prevent a favorable outcome. And secondly, it's probably very difficult to distinguish from all other causes of very similar pulmonary dysfunction in these patients, be it COVID-19 disease by itself, but also possibly other complications which can be seen after transfusion. So what about things as move forward? There has been an issue, obviously, with variants. You're all well aware of this progressive emergence of variants which evade immune responses. I'm not going to go into the detail of these variants here, but just to say that when you look and you have here different responses against different type of variants from on the left side here, each time the original virus up to XBB, which was a couple of months ago, still currently one of the current viruses, the current variants. You can see that there is for as we move forward, declining capacity to respond to neutralize effectively the virus. And this can be seen across different settings. This is after a vaccination, 3 shots, 4 shots. This is 3 shots plus a bivalent vaccination, or if you're vaccinated with a breakthrough, depending on what type of breakthrough you have, basically showing that you do have immune resistance, which is emerging. That has a different direct consequence for the monoclonal antibodies. And as you know, progressively, as we move from, let's say here, from B1 to BQ.1.1, there has been increased resistance to monoclonal antibodies. And so BQ1.1, none of them were sensitive. Currently, sotrovimab has perhaps some sensitivity with regard to the one of the variants of interest currently, which is XBB. Quite fortunately, it was rapidly demonstrated that a way to deal with these variants with regard to convalescent plasma was to collect high titer plasma from convalescent vaccinated donors. And this was shown early on in 2021, showing here that if you moved from a situation of just convalescent plasma against different variants to now convalescent plasma and vaccination, you would increase significantly the titers and also the ability to respond to variants to which the donor has not been exposed to. And this is how currently we collect plasma for our patients. This is shown here also, and this is a study by Heli Harbala and colleagues from the UK, where they did, I think, two very interesting things. First of all, they compared directly plasma from 2 trials, the REMAP-CAP trial, which I showed to you early on, and the trial of the Lipster study, which is called here the Argentinian trial. It's interesting to show here that when looking at the anti-IgG titer, so looking into the antibody response, one cannot say that there are major differences in between both of these plasma in the different trials, especially if we focus on the plasma which were within the threshold, admitted threshold for both of these trials, which is in the center of this figure here. And so, second thing that they showed here as well is one now looks at these convalescent vaccinated recipients. Once again, you increase significantly the response, the antibody titer. So similar things in France when we continuously assess the potency of our plasma. Here we're looking at plasma which was collected in July to October 2022, so a little less than a year ago, and looking at their potency and their response to two variants, BA5 and BQ1.1. BA5 is in orange, BQ1.1 is in green. You can see, and as expected, that there's a relationship in between the quantity of antibodies as assessed by ELISA versus their neutralizing capacity, as that's expected, and it's fortunate enough. And what you can see also is that despite the fact that these donors had not been exposed to any of these two different variants, you are still able to select plasma which are able to, which we generally qualify as high titer plasma, which is over 3,000 to 5,000, what you call binding antibody units per ml. So we can still currently identify and select among our donor pool donors who are able to have a sufficiently high titer antibody response. And this is just to show you over time, over the last trimesters, 2022 to 2023, the plasma we collect in France, on average, we are with the binding antibody unit per ml rather high, around 7,000, which is quite satisfactory, but it's becoming more and more difficult because recently infected donors, we have less of them, because recently vaccinated donors, we have less of them as well. And so we're currently in a difficulty with regard to the recruitment of these donors. As I mentioned earlier, we continued, nevertheless, and our clinicians, a number of clinicians are requesting convalescent plasma to treat their immunosuppressed patients. And just to mention here that there are various regimens currently used. I'm not to go into the details of this, but quite often, and notably for patients who are hospitalized with severe disease but are oxygen independent, and that can happen with immunosuppressed patients, they will start with obviously Paxlovid, and then they may get remdesivir or remdesivir plus convalescent plasma. If it's patients who are oxygen dependent, they will be getting CCP plus remdesivir most of the time, or obviously CCP only if they are after a failure of remdesivir. So just to mention basically what is going on, and on my last part of my talk, just to refer to the fact that we are currently into a new trial, which is called COVID-19, and this stems from a European initiative called Support E, which was funded by the European Commission, which was started end of mid-2020 and has for objectives to support high-quality evaluation of COVID-19 convalescent plasma throughout Europe. The objectives of this consortium, which gathers a number of investigators across Europe, some in the UK, Lise Esport, Dave Roberts, Heli Harvala, I'm talking about several others investigators, but in other countries as well in Europe. And their overall objectives here is to support high quality clinical evaluation, to try to achieve a consensus on the appropriate use of CCP to treat COVID-19 across Europe, and to promote best practices with regard to CCP use. In that setting, there has been a gap analysis performed with regard to the remaining questions. And based on, I think, a lot of the data I've showed you, it was felt that the need to assess the efficacy of very high titer CCP administered early, that is, before the worsening in hospitalization in clinically vulnerable individuals, and notably immunosuppressed patients, was what needed to be assessed. And that brought us to the COVID-19 and the design of COVID-19. Initially, we owe this to our English colleagues, once again, Lisa Escort, Dan Bradshaw, and David Roberts. And this trial, which was started now about a year ago, took some time to get started. There were issues regarding what could be considered for our patients, and especially in the consideration of the increasing resistance to monoclonal antibodies, the need for alternative treatments increased, and that brought us to the COVID-19 trial, which is assessing very early treatment with CCP, outpatient treatments. It's high amount of neutralizing antibodies, so it has a couple of rules written down here. If we stay with the BAU per ml I was referring to earlier on, we need over 4,000 units per ml. So it's basically what we're currently doing in France with regard to our patients, but it is high titer. So this plasma is infused within 7 days of start of symptoms in vulnerable patients. We had thought about two cohorts, one over 70 years old, but vulnerable, over 70 years old or felt to be vulnerable, equivalently vulnerable to COVID-19. And this was in patients which are not vaccinated. In a cohort 2, in immunocompromised patients, be it vaccinated or non-vaccinated, because obviously there it is of lesser importance. In both of these cohorts, which are independent, randomized standard of care versus high titer CCP, and the primary endpoint being hospitalization due to progressive COVID-19 or requirement for oxygen or deaths within 28 days from randomization. And this protocol is not 4 units of plasma, which are infused, but 2 units of plasma infused, and if possibly very early on, in order to stay within the few days after initiation of symptoms. This trial has, so as I mentioned, started a year ago. It's coordinated by my colleagues in France. It's with German colleagues, Uwe Schressenmeyer and Seifried. In the UK, I mentioned Lisa Escort, Daniel Bradshaw, David Roberts. And the Netherlands with Bart Rinders, and France with Eric Toussireau. We, at this moment, it's our German colleagues who have been especially active, and they were the first to open the trial about a year ago. They've randomized 95 patients in this trial. More recently, the Netherlands have opened a center with 10 patients randomized. In France, we're not doing too well. We've opened just 2 centers, and only recently, with 2 patients entered. And we're hoping that there will be centers being opened in the United Kingdom shortly. So this is the enrollment curve for this trial. It's okay, despite the fact that we would like to see something a bit steeper, notably more recently, especially in consideration of what I will be discussing now, is that all these patients have been recruited in only one of the 2 cohorts. The cohort 1, which is the vulnerable patients not vaccinated, for different reasons that I don't have time to get into, we were unable to recruit patients. However, in cohort 2, which is immunosuppressed patients, were able to do so. And in that cohort, so 107 patients enrolled in all, that's exactly 30% of the planned enrollment of 340 patients in each cohort. And what's planned at that time is that there's an intermediate analysis to look into the primary output endpoint, which is the frequency of hospitalization, and to see if there's a need to adjust the sample size. And we had put in a maximum patients per cohort, which we felt was achievable, which is a little over 1,000 patients. That intermediate analysis is ongoing. Currently, what we can say is that, and not completely unexpected in view of the, well, now not expected, but certainly unexpected when we thought about this more than a year or 2 years ago, was that the frequency of hospitalization is not close to what we could have expected based on the trials I referred to you earlier, notably the Lipster study or other trials, which said that was about a 30% hospitalization rate in these vulnerable patients. We're clearly going to be much lower than that. So that's going to mean that we need to think about what are the next steps for this trial. And now all options are currently open, and that's the current discussion and assessment we're currently making. Another issue which is very new, and that's in fact is from the day before yesterday, as we got some bad news from the European Commission with regard to financing. So we may also have another issue, which is funding. So clearly some issues we need to deal with at this point. So this is where we stand with the COVID-19 trial, with which again, we felt is that's where we need to bring answers, early administration in outpatient setting of high titer convalescent plasma in vulnerable patients and in particular immunosuppressed patients. So as a conclusion here, what can we say is that there is, at least I hope I've convinced you that there is increasing proof of efficacy of high titer convalescent plasma in immunocompromised patients hospitalized for severe COVID-19 or for vulnerable patients, not specifically immunocompromised, early in the course of the disease. These are really the two settings where there is, I think, a significant piece of data. One needs to keep in mind that possibly, and on rare occasions, CCP may be associated with an early transient lung worsening, which needs further investigations. In a more general sense, convalescent plasma, therefore, may be of a particular interest early on in the pandemic, clearly we're no more in that setting, or in a pandemic, that is before the vaccines, before the monoclonal antibodies, or after the monoclonal antibodies, if we could say so. It can be later on in a pandemic, upon emergence of immunoresistant variants, and that's the case where I think we are currently. And it could be throughout the pandemic for immunocompromised patients for whom we cannot propose an immunization regimen or other approaches which rely on the immunocompetence of these patients. And lastly, I think quite important, and I've been dealing with that today, is that when in comparison to other therapeutic approaches, convalescent plasma is easily accessible, it's quickly available, it is quote unquote low cost, although it does come with a price for sure. We call overall agile and adaptable, that is, that can collect plasma from a given variant about a month to 2 months after emergence of that variant. So that's still a time lag, which is still so much shorter than the time lag we would need for a monoclonal antibody, or if that was to happen, fortunately that has not happened, that we need to rethink about what type of vaccine we should be using. And so overall, an important, I would think so, early response measure to a novel pathogen with epidemic potential in the future. And to get back to the title of my talk about unmet need, there is in immunosuppressed patients today very much a need for therapeutics. Convalescent plasma is certainly not magic, but it's providing at this moment some relief in different settings. Still very much needs to be done and assessed before any kind of formal proof. But I think that is clearly a setting where such things are needed today. Thank you very much.
Thanks, Pierre. And I guess we have some time for questions online. I can't see the people online, but I guess.
Yeah, happy to take questions online.
Or on site.
Yep.
Maybe I'll start. Thanks, very interesting. Is there any data from the recovery trial about some of these questions in terms of immunocompromised high titer antibody, or there was no subgroup analysis by those characteristics in the recovery?
So if I'm correct, I don't think there on the recovery trial there was information with regard to the subgroup immunocompromised patients to the different of the REMAP-CAP trial. That's why we're able to show data for the REMAP-CAP. With regard to the titer, what we can say, and I showed this very briefly, it doesn't look very different than what was in the Argentinian trial, but I'm not aware of an analysis of dose response. I'm sure it's probably ongoing, but I must admit I don't know about it.
I really enjoyed your talk. Thank you very much. I feel like I've learned a huge amount. So it was an area that I didn't know very much about at all. And so I'm interested in what you kind of touched upon a little bit of these secular changes. And I was kind of thinking there's secular changes that are happening with the variants of COVID, but also probably with your donor population as well, if who's eligible to give you blood at the right time. And so on this final slide, you did start talking about how adaptable it is and how you need this probably 1 month period between, so that you're always using the right blood at the right time. But perhaps my question is around that actually. So how important is it to have the right donor population? And then do the variants change so much that you can't keep up with it?
Okay, well, so first of all, and that's why I just put up this last slide, that I did want to, obviously, all this, we owe this to the donor. I mean, it's the donors who allow us to do this. So
Yeah.
I would want to acknowledge here very much the important role. That's why I put that slide up, just but it is important and indeed. And the availability of donors to undergo apheresis plasma, we're so, I mean, lucky that is possible, and that we have donors accepting to do so. Now, with regard directly to your question, how well are we keeping up? I mean, it's, we have not, taken plasma collected 2 years ago and looked at its ability to neutralize XBB. But I bet we would not be happy with this for sure now. So how close can we be? Currently, and I decided to go this, I'm sorry, I didn't have perhaps enough time to go through this, but we've been able currently to be reassured that if we go the last two variants, if I would say so, something like that, we're okay. That is, we can still select out based on the antibody content a plasma which we reasonably which we think reasonably that it has the neutralizing ability against the variant to whom that donor has not been exposed. Now, it's a question of kinetics. Now, how long is that? I would presently, if I would have some kind of if I could have a wish list, I would want to be able to exclusively collect plasma from donors who've had at least one COVID-19 episode, but I put it that way, within the last 2 months. But we're not able to do that. It's difficult to find. They exist. So we all know about people around us who have COVID-19, but we really now need to go to them and kindly hope that they would accept to give plasma. Because other than that, I think we're in difficulty, and our clinicians are themselves telling us sometimes it's difficult that it's not controlled in any ways. We are, obviously, and I didn't say that, and I take the opportunity, we're collecting that data on all those patients that demand to access, but sometimes the impression of some of our clinicians is that we're not, our plasma may be not as potent as it used to be, because we may be running into the type of trouble of inadequate.
Do you think some of these early trials that you showed, would that have been a problem there, that they weren't using the right donor population to show the positive effects that you were?
But early on, there was no, let's say, vaccination, so it was just not there. But we could have focused, I think, all of us collectively at a much higher titer. I myself discovered the data of these Argentinian hemorrhagic fever afterwards, and I was unhappy with that, because it was just right there, laying in front of us, what we needed to do. And I mean, for myself, only for myself, I think I would have pushed things a bit differently.
Yeah. Thank you.
So,
I mean, at the other extreme, how much would natural infections have protected people from severe outcomes before the infections? I'm thinking about children.
I missed the question. Sorry, how many? Sorry.
Why didn't children, for example, have severe COVID-19 outcomes? Yet probably they would have been anyway. Is it a natural infection?
So you're asking me about the physiopathology of COVID-19 in children. I mean, is that the case? Just to say that I'm not an expert in that field. There are children who are doing severe forms of COVID-19 in a lesser frequency. And it's true also in young adults versus late adults. And there are some hypotheses, one of them being the presence of autoantibodies against interferon alpha, as an example, type 1 interferon, which the percentage increases with time. And you have them more frequently in older patients, so that could be an explanation for severe COVID-19, but I'm not sure am I answering your question or maybe not?
I guess I'm wondering that here you are sort of looking at treatments for people who have already had a severe disease, which is more hospitalized.
Oh, you're talking about early treatment?
Yeah.
Well, indeed, yes, and that's what was suggested in early on in the Argentinian hemorrhagic fever studies, that one needed to arrive early, and indeed the data available up to now, that suggests that intervening early before worsening and before hospitalization is certainly is a way to go. Is that your question?
Yeah, I guess I'm thinking for the immunosuppressed people, if there's a way to challenge their system before they sort of get hospital.
But yes,
That's the idea of positive outcome, more than waiting.
that's what we're trying to do with COVID-19 currently is that treating, randomizing such patients early on before they are require hospitalization. And indeed, we would like to see this. And by the way, I think it's something we're looking into viral load and the genomics of the virus in these recipients. And indeed, and I think that's what you're referring to, is that early intervention, early immunotherapy intervention in these patients may have quite a favorable outcome with regard to such aspects in those patients where often they have prolonged circulation of the virus, prolonged virus and disease. I don't know how to say this. I mean, virus burden for a long time. Sorry.
Excellent. Well, thanks. If there's no other question, we'll close it here. So,
Excellent.